This episode of the Nurse Practitioner Podcast is sponsored by Dakin's Wound Cleanser. When you're treating persistent, hard-to-heal, or complex wounds, you need a solution you can trust, like Dakin's Wound Cleanser. Just how powerful is it? Dakin's Wound Cleanser has been proven to kill even highly resistant bacteria like MRSA and VRE within only 30 seconds. It's non-cytotoxic, shelf-stable for 2 years, and more cost-effective than other wound cleanser brands. When you need a solution you can count on, ask for Dakin's. In this episode of the Nurse Practitioner Podcast, Dr. Julia Rogers discusses having a voice in the payment system based on RVUs for CPT codes. Thanks again for joining us, Julia.
Thank you for having me.
What is the importance of nurse practitioners having a voice in deciding relative value units, or RVUs, assigned to the current procedural terminology, or CPT codes?
It is so important for nurse practitioners to take an active role in ensuring the services that they provide are not only documented accurately, but captured on encounter claims to maximize reimbursement. Nurse practitioners are valued members of a healthcare team, and over the past 20 years, there has been exponential growth in the numbers of nurse practitioners, with over 355,000 in the United States in 2022. An understanding of the reimbursement system is key for survival in today's healthcare environment, as erroneous coding may result in a substantial loss of revenue or imposition of monetary penalties. Nurse practitioners already contend with disproportionately lower reimbursement. For example, Medicare, Medicaid, and even some third-party payers reimburse nurse practitioner services at 85% of the physician rate for the same billable CPT code service. Interestingly, nurse practitioners and other APRNs are among the top providers performing and billing for many CPT code services reimbursed by Medicare. A factor that will ensure correct billing and coding is for nurse practitioners to become competent in the CPT system and the payment system based on RVUs.
Thanks for sharing those eye-opening statistics. Can you demystify CPT and RVUs?
Let me start with CPT. What many nurse practitioners do not know is that the CPT system was developed by the American Medical Association to provide a standard language and numerical coding as the process used to communicate services that are provided by qualified healthcare professionals to the Centers for Medicare and Medicaid Services, as well as to third-party payers for reimbursement. CPT codes are used by providers to describe tests, surgeries, evaluations, and other medical procedures that are performed by the healthcare providers. RVUs are a measurement of practice efficiency and patient complexity that is tied to each CPT code. An RVU has 3 components: provider's work, practice expense, and professional liability insurance expense. For example, a nurse practitioner's work RVUs include clinical skills and time needed to treat a patient during an encounter. Work RVUs account for nearly 51% of the total RVUs for a given service. Practice expense RVUs consist of the practice's overhead, such as expenses for the building space, equipment, office supplies, and clinical staff, such as the work of licensed practical nurses and registered nurses. This accounts for almost 45% of the total RVU. Professional liability insurance expense RVU comprises the cost of malpractice insurance premium and accounts for the final 4% of total RVUs. Medicare and Medicaid services also adds geographically adjusted components to the RVU in order to arrive at a total RVU for every CPT code.
We appreciate the clarification. How can nurse practitioners have a voice in the RVU value placed on CPT codes?
To establish value for the work component of a CPT code, practicing clinicians nurse practitioners, nurse anesthetists, nurse midwives, physician assistants, and the physicians are surveyed by medical organizations in order to rate the value of work by using magnitude estimation methodology. If nurse practitioners typically perform and bill for a CPT code being reviewed, then an email is sent to a random sample requesting that the nurse practitioner members complete a survey outlining the requirements of the CPT code, including the time, the level of difficulty, level of risk, and supplies that are used throughout the procedure. This work is critical because it informs the correct valuation of CPT codes, impacting the reimbursement level received by all billing clinicians.
Who sends surveys out for nurse practitioners to have a voice in valuing a CPT code?
For nurse practitioners, it is the American Nurses Association that participates in the survey process that's sponsored by the American Medical Association Relative Value Scale Update Committee, or the RUC Committee. These are important surveys that provide data to help establish appropriate payment for services performed by nurse practitioners and other qualified healthcare providers. These surveys are conducted for either new CPT codes, existing codes that have been identified for review for a variety of factors, such as growth in utilization or a change in who can actually perform the service, or if the code descriptor has been substantially revised.
So, when are surveys sent out by the American Nurses Association?
This survey process happens 3 times a year, over the summer, in the fall, and early spring. When services are being surveyed that are performed by nurse practitioners, the American Nurses Association will participate by sending the survey to a random list of ANA members via email. It is an online survey, so you can access it directly from your computer. If you receive such a survey, I really strongly encourage you to participate if you have the experience with the service being surveyed.
Thanks for the suggestion. What types of questions are on the surveys?
The survey is going to ask you to estimate how long it takes you to perform the procedure or service, and then compare the intensity of the surveyed service to another service that you also provide. And finally, you will be asked to estimate a work RVU value for the service.
What happens once the information from the surveys is collected?
The data collected is used to develop recommendations for the work RVU of a service and time allocated to perform the service. These recommendations are forwarded by the Healthcare Professionals Advisory Committee, or HCPAC, which is composed of representatives of organizations such as the ANA that represent qualified non-physician healthcare professionals, and the Relative Value Scale Update Committee, the RUC Committee, which is a volunteer group of 32 physicians and over 300 medical advisors and other healthcare professionals to the Medicare agency. The Medicare agency then uses this data in determining the new value for a code.
Thanks for the info. Can a nurse practitioner who receives a survey forward it to another NP colleague to increase the response rate?
Unfortunately, these are random surveys, so you cannot forward them to other members in your practice. But if you are the one that receives the survey, please participate and respond based on your experience.
What happens if NPs do not complete the surveys?
When NPs engage in these surveys, then CPT values are adequately represented, and NPs receive proper recognition and reimbursement for their work. When NPs fail to engage in these surveys or just dismiss a request to describe their work, then only the physician's opinions are heard, and the RVUs for CPT codes may decrease. An improper valuation of a CPT code decreases a nurse practitioner's total work RVUs, which potentially lowers nurse practitioners' salaries if they are compensated by their entire work RVUs. Improper CPT valuation also directly reduces the reimbursement for a nurse practitioner's work. In recent codes surveyed, only 1.11% were completed by nurses. This means the input used to revise codes primarily submitted by nurse practitioners were obtained from physicians and other qualified healthcare professionals. That's almost 99% of the information was obtained from physicians or other qualified healthcare professionals. So it is only when nurse practitioners provide their opinion by completing these surveys that their clinical expertise and knowledge can be heard by the RUC, Centers for Medicare and Medicaid, and other paying parties.
Thanks for sharing those insights. What other changes can nurse practitioners do to make sure their coding and billing is accurately captured?
One of the things nurse practitioners can do is to code to the highest specificity. So the codes that nurse practitioners should be using are the ones that most accurately match what you are choosing for the code and the code with the most digits or the one with most specificity. You also want to make sure that you are coding for your scope of practice and licensure. Caution is really needed to avoid codes that pertain to certain populations and specialties that are unrelated to your specific practice as a nurse practitioner. So depending on the state in which you practice, remember that some nurse practitioners are not allowed to diagnose certain illnesses, while restricted nurse practitioners can code for follow-up care, and issues may arise when using codes for the initial diagnosis. Remember that in Incident 2 billing, the physician must set up the initial plan, so a nurse practitioner cannot use a code for an initial diagnosis. Also, make sure that when a patient is released from a hospital, that you are following up and providing transition of care activities for this patient. Certainly, you can miss out on reimbursement if no phone call is made. Not that the claim would be incomplete, but rather that taking the step of calling the patient out to come up with a follow-up plan would actually increase the Medicare reimbursement. Also, make sure that you are documenting everything. The more your coding reflects a patient's chart contents, the more accurate it will be. For example, social determinants of health are often omitted from coding. As mentioned earlier, you can get credit for calling the patient as part of their transition care management visit after hospital discharge. However, detailed documentation of these efforts is imperative. Nurse practitioners also must be aware of what can be billed. So common CPT codes will fall under categories that are defined as the AMA as a Category 1 code, has descriptors that correspond to a procedure or a service. These codes range anywhere from 00100 to 99499, and they're generally ordered into subcategories based on procedure, service, type, and anatomy. Category 2 codes are alphanumeric tracking codes, and they are supplemental codes used for performance measurement. Using them is optional and not required for correct coding. Category 3 are temporary alphanumeric codes for new and developing technology or procedures and services. They are created more for data collection and assessment, and in some instances, payment of a new service and procedure that currently don't meet the criteria for a Category 1 code. Some of the more common CPT codes that nurse practitioners should be aware of are the codes for evaluation and management, transition care, chronic condition, and routine annual visits. The evaluation and management codes for new patients are 99202 all the way through 99205. For established patients, they're 99212 through 99215. There's also codes for new patient home visits and established patient home visits. For the transition of care, this is reaching out to the patient after discharge. Those codes are 99495 and 99496. There are also codes for adult wellness by age and also well child checks by age. There's Medicare preventative care, such as the welcome visit. That is a G code of G0402. The first annual well visit is a G0438, and subsequent annual visits are G0439. There are also numerous codes to chronic care management, as well as medication therapy management, education and training for self-management, and of course, diabetes self-management training and education.
Thanks for that comprehensive list. Where can nurse practitioners find how many RVUs are assigned to each CPT code?
There's a couple of websites that nurse practitioners can go to. First is the Federal Register Fee Schedule. This is put out every year, usually in November of the preceding year of when they're coming out. So for example, the Federal Registry Fee Schedule for Physician Services for 2023 came out in November of 2022. And that can be found at federalregister.gov. To find out the assigned RVU for each CPT code, or in order to determine annual dollar conversions, which change every year, you can go to cms.gov.
How are RVUs assigned to each CPT code?
As stated earlier, an RVU is made up of three components: the nurse practitioner's work, practice expense, and malpractice. Medicare payments are determined by RVUs and then multiplied by a monetary conversion factor and a geographic adjustment. Now, the monetary value changes annually. This year, it is $33.89. For example, removing a foreign body from an eye, which is CPT code 65205, is assigned 0.49 work RVUs. But performing a minor eye wound repair, which is CPT code 65270, is valued at 1.95 work RVUs, because the work required to repair the eye wound is roughly 4 times greater than the work that is involved with the foreign body removal.
How are nurse practitioners reimbursed for services rendered if based on RVUs?
When work RVUs are used for provider compensation models, where the intent really is to pay a provider based on the amount of work performed. This is blind actually to the payer mix or the amount of revenue generated. So compensation then is derived from total work RVUs and then multiplied by a dollar conversion factor set up by the facility.
Do you have any final thoughts on coding and billing practices for nurse practitioners?
I just want to reiterate the importance of understanding how to appropriately code for services using the CPT system and how to determine the RVUs associated with each code billed. In addition, it is so important for nurse practitioners to fill out any surveys that they receive in order to assess the appropriate number of RVUs to assign a CPT code. As I stated earlier, nurse practitioners are many times the highest user of a CPT code, but are not reimbursed appropriately because of the lack of input received from surveys. Finally, nurse practitioners need to remember that documentation is paramount for coding and billing and receiving appropriate reimbursement.
Thanks for joining us today, Julia. We really appreciate it.
Thank you.
For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at the Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.